about the definition of lymphocytic leukemia, the pathogenesis of it, the etiological factors, the clinical findings, the lab diagnosis, and we'll be discussing about the prognostic markers and the stratification and the scoring system of the lymphocytic leukemia. And this will be followed by the chronic myeloid leukemia. We'll be just discussing about the different classification systems of the chronic myeloproliferative disorder. Because of the paucity of the time, I will be just restricting myself to chronic myeloid leukemia, in which again we'll be discussing the definition, pathogenesis, different stages of the chronic myeloid leukemia, and the lab diagnosis in great detail, because that's very important, followed by multiple myeloma. There's a plasma cell dyscrasia, where we'll be discussing the definition, the lab diagnosis, the diagnostic criteria laid down by the International Myeloma Working Group Forum, and the prognostication based on the cytogenetics molecular studies and the immunophenotyping by flow cytometry. So we begin with chronic lymphocytic leukemia. So the chronic lymphocytic leukemia, as the name suggests, it is chronic, that it is for longer duration, not abruptly or acutely arising within few days, and it is involving the lymphoid cell, and it is a leukemic process. That means we are expecting the lymphocyte cell count to be increased in this. So it is a malignant clonal disorder of B lymphocytes when we define this. That means it's a clonal disorder and it is neoplastic, which is characterized by accumulation of monomorphic mature appearing small lymphocytes in blood, bone marrow, and when they're deposited in the lymph nodes and in spleen, we call them as small lymphocytic lymphoma or SLL. The congener of the leukemic phase of CLL is called SLL, that is small lymphocytic lymphoma, which I will be discussing in my next series of lectures on lymphomas. The diagnostic criteria for CLL is absolute lymphocyte count of equal to and more than 5,000 cells per liter, which are persisting for more than 3 months without any etiology which can be ascribed to it, that is lack of infection or any other antigenic stimulation which can lead to it, and the usual therapy to relieve the infections and antigenic stimulation do not relieve this situation. That is, we have to have 3 components in this, that is persistence of lymphocytosis with an absolute lymphocyte count of more than and equal to 5,000 per liter lymphocytes. So now we discuss what is the epidemiology, that is what is the distribution of the CLL throughout the globe, and what is the gender and the age which is involved. When we look into this, we find that the CLL is more common in the Western population compared to the people who live in the East or the Far East, with more involvement of the males and the females, with peak age incidence of more than 60, ranging from 65 to 69 years, and there is a familial predisposition, so much so that there is a 30 times increase in the first degree relative of CLL patient. That means if one of the family member suffers from it, there's a high chances of the other family members by blood relation to have more than equal to 30% time increment or the predisposition for having CLL. Now, what is the cell of origin? Whenever we talk about the leukemias and lymphomas in my next lectures also, I'll be telling you that each leukemia or lymphoma, and for that matter, each malignancy arises from a cell. The cell of origin is very important because that will decide the nature, the biological behavior, the response to the therapy, and the prognostication. The cell of origin of the CLL is the memory B cell, which is CD27 positive, And there are two pathways through which this can arise. One is from the pre-germinal center lymphocytes, which are lacking immunoglobulin heavy gene mutation, and the other one is without the with the gene mutation. That is the post-germinal and the pre-germinal. This is based on the lymph node architecture. We have the germinal center in the lymph node that I'm sure you must be aware from the first preliminary knowledge of yours, that in the pre-germinal lymphocyte, the cells which have not been put up into the germinal center after the antigenic stimulation, that is the naive B cells, they are lacking the IgVH gene mutation for the obvious reason because they have not been exposed. But the other cells are the post-germinal center cell type, which have got the gene mutation, which is the heavy chain region of the immunoglobulin, and they comprise another compartment of the CLL as per the cell of origin and the pathogenesis involves. This is very important to understand because in the prognostication, and when we talk about the favorable and the unfavorable prognosis in the later part of the lecture, this is a very, very important, in fact, one of the key factor for the prognostication. The other ones are the major cellular defect in the cellular accumulation. Basically, the CNM is a chronic lymphocytic leukemia, so thus it has got more, resistance to the apoptosis rather than the cell proliferation, which was more the feature of acute leukemia. Whereas in this, the cells resist the cell death and they live very long and they remain in the quiescent phase, something like G0 phase. That is where they are very difficult to be killed, even by the chemotherapy. So that is the problem. Though it is very quiescent, but when it goes into the division phase, then the cells could be little bit amenable for the chemotherapeutic response. Unfortunately, the majority of the CLLs, they belong to the latter type, where fortunately they belong to the site where the IgVA gene mutation is present compared to the part or the component where it is lacking. So it is understood that the clinical features will be either asymptomatic. Why? Because the cells are in the quiescent phase, they're dividing very slow, they're there, they remain like that for quite some time, they do not occupy much of the bone marrow areas, and they will be just silent with very mild anemias or maybe mild lymphadenopathies or maybe not that. Then we have other group of patients who can have fatigue, weakness and weight loss when the cell mass or the lymphoid cells which are atypical, their mass increases in the marrow and in the peripheral blood, or there could be involvement of the lymph nodes as well or the organomegaly spread. What happens when the marrow is involved? There could be two reasons for the other manifestations like febrile conditions, pallor and bleeding, because the normal hematopoietic component will be replaced by the clonal population of the lymphoid cells, thus resulting in the neutropenia, resulting in the anemia, and resulting in thrombocytopenia. So there could be the first presentations in those who have got very high lymphoid cell index. There could be lymphadenopathy and or hepatosplenomegaly, thus bringing the tumor load much higher in the individual. Now, in general, what is the lab diagnosis schema, which is very important? In hematology, the first and the foremost thing is the complete blood count with peripheral smear. This is a one single tool which gives you very, very important, immense information about what is happening in the body, because if any of the component of the leukocyte is raised and with atypical cells in the peripheral smear and the other components like RBCs and the platelets reduced, then we have the idea, fair idea, that what this person is suffering and at what stage of the tumor bulk or the tumor load this patient is. So what we see a persistent absolute lymphocytosis of this much amount for more than 3 months, as I told you, as a diagnostic criteria. Then we have the hemoglobin, which could be normal or reduced. If it is normal, it is asymptomatic or a stage where the patient can be just kept in the wait and watch situation, or it could be reduced, which we'll be discussing in the subsequent slide, how it is to be titled. Then we have platelet count, which could be normal, again wait and watch, or it could be showing thrombocytopenia, again a call for the treatment. The reticulocyte count is very important in these cases, especially when we are expecting autoimmune hemolytic anemias. As in, I'm sure in the hemolytic anemia, especially AIJ, this must have been taught to you that all lymphomas and CLL have a very dreaded complication called AIHA, and at times, especially in CLL, this could be the cause of the death of a patient, and a patient might not die of CLL per se, but it can die of complications of AIHA if not recognized and treated on time with a simple treatment of steroids and, of course, the treatment of the disease as well. So peripheral smear will show you small monomorphic population of monoclonal B cells with clump chromatin, scant cytoplasm with indistinct nucleoli, smudge cells, and prolymphocytes. So how do you see them? This is the peripheral smear. These are smudge cells. You can see the cells are smudged. The morphology cannot be appreciated. These are the cells which have got scant amount of cytoplasm, and the chromatin is very clumpy and it is irregularly clumpy. You can see it is clump, 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 and then there are some areas not so dense, they're rarer areas. So there is alternate areas of ratification and clumping. This is called checkerboard appearance, or the alternate areas of dense clumping and the ratification. This is one odd nucleated RBCs indicating that the marrow is stimulated and is completely replaced by the atypical lymphoid cell. And you can see there's hardly any other cell, the normal component. Also, one can see in this particular field there are no platelets. So that means we are expecting this patient to have anemia as well as thrombocytopenia with lymphocytosis and smudge cells. This is a photomicrograph which is showing the lymph node involvement by the CLL. This is a lymph node which is showing a complete replacement of the architecture of the lymph node by a similar kind of cells all over. You cannot appreciate any corticomedullary differentiation. There are hardly any follicles. You just have simple, small, mature lymphocytes which are just occupying the entire lymph node here. This is the capsule and the subcapsular sinus. And in the higher power, you can see that there are cells with a beautiful checkerboard appearance, the denser chromatin, the rarer areas, and a prominent nucleoli. These are prolymphocytes with prominent nucleoli and or slightly larger than these cells which have got checkerboard appearance. So the presence of prolymphocytes, the clumpy lymphocytes, the atypical lymphocyte, and smudge cell peripheral smear with and without anemia and thrombocytopenia makes it chronic lymphocytic leukemia. Here it is SLL, small lymphocytic lymphoma. There is another view which is showing the smudge cells. These are all smudge cells and almost uniform size of small cells which are clumped, hardly any lymphocytes here. Here, in contrast with the previous year, you can see the platelets, one here, and one here. Again, this appears to be reduced, but not as much as it was in the previous case. Now, based on these features, we morphologically subclassify the CLL cases into classical CLL, CLL PLL, and atypical CLL. So what do we mean by this classical CLL? Here, more than 90% of the cells are small cells and only less than 10% are prolymphocytes. This is called classical CLL. Whereas in CLL PLL, where you get the admixture of both the cells, but the prolymphocytes are less than 54% and ranging from 11 to 54%. Then we have got pure PLL, which is pre-lymphocytic leukemia, where the prolymphocytes are more than 55% and has got intermediate prognosis compared to CLL. There's another subtype of CLL, which is atypical CLL, where we have got 15% cleaved or the plasmacytoid lymphocyte with less than dense chromatin and less than 10% pro-lymphocytes. So here we have to pay attention to these cells. That means 15% cleaved cells, which are akin to centrocytic cells, or plasmacytoid cells. That means the cells which are now getting the post-germinal genotype or phenotype. That means they have been antigenically stimulated and they represent immunophenotypically different antigenic expressions. Then on the bone marrow aspirate, though as per the international working CLL group recommendation, these lymphoid cells should be more than 30% of the cells, but DNA is not diagnostic, can be used for prognostication. For the diagnosis of CLL, what we need is a simple peripheral smear, absolute count in the CBC and the flow cytometry with classical IPT immunophenotypic expression, which we'll be discussing in the subsequent slides. But bone marrow is done for the purpose of excuse me, for the purpose of basic cytogenetics and molecular at the time of diagnosis for the revised prognostication index to be calculated. The next is, along with the bone marrow, we do the bone marrow biopsies. In the bone marrow biopsy, again at the baseline, we have to see the deposition of these lymphoid cells in various locations. It could be interstitial, it could be nodular, it could be mixed, or it could be diffuse. This interstitial pattern, where we see the cells irregularly dispersed throughout the interstitium and mixed with the normal hematopoietic cells. Fortunately, this is the most common pattern of the CLL cells to be dispersed in the bone marrow biopsies. Also, rarely we can have paratrabecular, that is along the trabecular, bony trabecula, that is the dispersion. Where also we can have a nodular cohesive cells, that is the atypical cells separated by the normal cells. This is also next in the percentage or in the occurrence of the frequency of occurrence next to the interstitial pattern of deposition. Then we have mixed pattern, which again comes next to these two, interstitial followed by nodular followed by mixed, where we can have different components of all these patterns, interspersed, mixed, and nodular, and very rarely paratrabecular. And the diffuse, fortunately, is not so commonly seen, where the complete obliteration of normal hematopoietic cells by atypical cells is seen, and but it is not that uncommon also. Especially when we talk about and we correlate with the staging, many times it shows the linear correlation with the staging of the CLL, that is with a larger bulk of the CLL cell, poor prognosis, other factors, the diffuse pattern of involvement at the baseline could be appreciated. Now we come to the flow cytometry, which is a very important tool of any hemato-oncology workup of any leukemias or lymphoma in the leukemic phase in the hematology. So what we do, we make the cells of the CLL patient, we collect the blood in the EDTA as we do for the CBC. The same vial can be put up for the flow cytometry. As I said, the bone marrow is not diagnostic, but it is for prognostication, for the basic workup at the baseline, and for the cytogenetics and the molecular study, and for the bone marrow biopsy assessment for the pattern of distribution and the bulk of the CLL cells assessment. So in this we subject the blood cells for the flow cytometric assessment by tagging the cells with the fluorochrome tagged antibodies against the antigens which the cells express, which I explained you in the previous lecture, that as per the ontogeny, when the cells are maturing from immature to highly immature to maturer and very mature cells, they express certain markers and release certain markers. So as I said, these cells are 27 positive cells, which would be pre-germinal or post-germinal. So they will have certain, antigenic expressions, and they, as we know, they are B lymphocytes. So we are expecting the lineage-specific B cell markers, which is CD19, 79B, 22B, and in addition to these two markers, we have a T cell marker CD5, which is present here because this marker is also present in the naive B cell, which are close to mental zone. So as expected, very classical and important triad of immunophenotypic expression is CD19, 5 and 23 as moderate to strong positivity, especially the co-expression of 5 and 23 with weak surface immunoglobulins and weak positivity to maybe negativity of these markers, and FMC7, which has to be a negative expression in classical CLL. There are two markers which are for prognostic implications, CD38 and ZAP70. They are basically related to the IGVH gene mutation as we discussed previously. So if they're expressed, prognosis is poor. Based on the IPT, we have a scoring system for the diagnosis of chronic lymphocytic leukemia, and the score is provided 1 or 0 if any of these combination happens. Surface immunoglobulin being weak is considered as 1 score. If it is strong, it is 0. CD5 is positive, moderate to strong is 1. If it is negative, it is 0. If 23 is positive, which is moderate to strong, is 1, and negative is given a score of 0. If FMC7 is negative, it is ascribed a score of 1, whereas if it is positive, it is given a score of 0. CD22 or 79B, as I explained earlier, if it is weak or negative, it is 1. If it is strong positive, it is given the scoring system of 0. That's how we decide whether it's a classical CLL or a typical CLL, or there's a transformation which is happening in a pre-existing CLL, and that bears the implication for prognostication. So based on the IPT, that is immunophenotyping, and the overall stage scoring system, we do the IPI, that is the International Prognostic Indexing, which is by WHO 2016. If the total score is low, which is 0 to 1, we use the policy of wait and watch. We do not treat these patients, and they do pretty well even without the treatment. Then the 5 years overall survival is 93.2%, and intermediate scoring, that is 2 to 3, is given no therapy unless the patient in between develops severe symptoms, and the 5-year overall survival is 79.3%, lesser than the previous one. If the score is higher, between 4 to 6, the treatment should be started immediately unless patient is completely asymptomatic. So a lot of stress is given to the symptomatic or the manifestation of the symptoms in CLL patients for initiation of the treatment. And here the survival is median, that is 63.3% in 5-year when we consider 5-year overall survival. Very high score between 7 to 70 is required for the initiation of therapy immediately with novel drugs like Bcell2 antagonist, which has started, which is the treatment of choice these days. Both the kinase inhibitors, especially suratinib, which is a newer drug which has come in the last 2 years, and it is being given in combination with various previous treatment regimes, which I'll be discussing very briefly because that is not part of your, undergraduate curriculum. And here the 5-year-old survival is very low as expected, 23.2%. So based on these factors, we do the prognostication for CLL. Uh, First and foremost is the gender. The females do better than the males. Age is important. If the age is more than 7th decade, poor prognosis. If the Binet score is lesser, which I'll be discussing in my next slides, stages 0, 1, and 2, the scoring is based on the presence of lymphadenopathy, anemia, thrombocytopenia, and of course the lymphocytosis. We classify them as Binet and the rise stages 0, 1, and 2. And if the Binet stage is B and or C and the rise stages 3 and 4, this is a poor prognosis. If the lymphocyte count is 12 raised to power 10 to power 9 per liter and lesser, it is a good prognosis. If it is more than or equal to, it is a poor prognosis. Typical morphology of CLL is a good prognosis. Atypical is a bad prognosis. Number of smudge cells quantitation is very important. If it is more than or equal to 30%, it has a good prognosis. And it's a very simple, modality. Just on peripheral smear, if we do the differential count, we give the number on the smear itself. It can prognosticate patient better. If it is less than 30%, it has a poor prognosis. Pattern of marrow involvement, as I said, non-diffuse is always better than diffuse is poor, and it's a telltale sign of the bulk of the CLL cells into the marrow. Lymphocyte doubling time is very important. And what does we mean by this? Suppose today we do the CLL count, the absolute lymphocyte count, and do the workup, and after a year, the count is nearly the same. That means the cells are not multiplying fast, they are not doubling, and this gives a better prognosis. That means the patient is in the quiescent phase, treatment might not be required for it, and the survival will be better. Vis-a-vis, when we have a poorer prognosis where the doubling time is increasing every 3 months, 6 months, or 4 months, or 5 months, when we do the follow-up, we find that the cells are dividing. CD38 expression is positive in less than 20% cells, and it has a better prognosis. Worst prognosis positive in more than or equal to 20% cells. ZAP70 expression, again, it is poor when the positivity is seen in more than 20% of cells. IGVA gene mutation is considered to be a good prognosis, as I told in my previous slide, whereas it is worse when it is unmutated. Serum markers like LDH, CD23, and beta-2 microglobulins are normal. So it's a good prognosis when they're raised. It's a very poor prognosis. Genetic abnormalities like 11q deletions, 17p deletions, and trisomies of 12 are poor prognosis. Fortunately, 17p deletion is one of the least commonly found abnormality, whereas 13q deletion, if at all, is found along with 12p, is more commoner one and has got a better prognosis. So a minimal panel of 13q deletion, 17p deletion, 12p, and 11p is a must if we are doing the FISH analysis, and if we are doing the basic cytogenetics along with this, we must look for the trisomy, because trisomy 12 is very easy to pick up on basic cytogenetics, and we can say the patient has got poorer prognosis. Now we should talk about the transformations. That is a transformation from a quiescent CLL stage to a high-grade lymphoma or a Hodgkin's disease, which can happen in the CLL called Richter's transformation. And the Richter's transformation most commonly is in the diffuse large B-cell lymphoma, which is about 2 to 8% and has got a poor prognosis. But rarely it can happen to other non-Hodgkin's lymphoma too, very rarely to Hodgkin's disease, which is not even 1% to happen. So this is all about the chronic lymphocytic leukemia we have in the morphology. Now we talk about the staging system. That is, we discussed in the prognostication, international prognostication group of the CLL, the recommendations, the staging was very important. That is, RIE system says if it's a stage 0, it is lymphocytosis only, no anemia and no thrombocytopenia. If it is stage 1, the lymphadenopathy comes. If it is stage 2, organomegaly comes. If it's stage 3, anemia with all these features come. Minus these features, if the only lymphocytosis is there and anemia is there, straight away it goes to a stage 3. And if thrombocytopenia comes, it's a very poor prognosis and straight away it goes to stage 4. So even if the lymphadenopathy and organomegaly are not there, if thrombocytopenia arises, which is stage 4, and the cutoff for the thrombocytopenia is 100,000 per microliter, and for anemia less than 10 grams per deciliter, this is the cutoff. And now when we talk about the survival patterns of these stages, stage 0 has got more than 10 years overall survival, 1 and 2 have got 7 to 9 years, and this has got poor prognosis with survival of 1.5 to 5 years. So thrombocytopenia and anemia in CLL are grim prognostics markers and a call for treatment to be initiated or to be, aggressive. Now we talk about the staging system, which is Binet type, and if we tell about the RIE system, this is Dr. I was one of the pioneer hematologists of India from Kolkata, and he was internationally acclaimed way back in 50s about the hematology, especially the hemato-oncology, and he did a lot of work on the Yes. So what we give the treatment only when the anemia, thrombocytopenia, lymphadenopathy, and automatically develop. So that's what I told you, and that's the way we should treat them. A very small brief passage to a condition called monoclonal B-cell lymphocytosis, in which the clonal B lymphocytes are increased, but they are less than 5,000 per microliter, which is required for the CLL cutoff. And there is absence of lymphadenopathy, organomegaly, or any cytopenia or disease-related symptoms, or any pressure symptoms or anything which can be ascribed to CLL is not there. Why it is important? Because monoclonal B-cell lymphocytosis will show clonality and in due course of time can convert into the lymphoma or leukemia. So that is why these patients needs to be picked up and they need to be followed up and they cannot be ignored just like that. Now we come to the next part of the lecture, which is chronic myeloproliferative disorder, in which we have got multiple diseases, but due to the paucity of time, I'll be just restricting myself to chronic myelogenous leukemia. And as per the classification, we have got CML, polycythemia vera, essential thrombocytosis, idiopathic myeloproliferative disorders, chronic eosinophilic leukemia, not otherwise specified, chronic neutrophilic leukemia, myeloproliferative neoplasm, which are unclassified. So I'll be just restricting myself to CML as part of your lecture today. CML is the most common myeloproliferative disorder. It's a neoplastic proliferation of hematopoietic stem cells with prominent granulocytic proliferation. It's the most important component of this. So what you will have in a patient of CML, you will have a bimodal cell population and a myeloid bulge. Whatever you will have just the hematopoietic cells of granular myeloid precursors series with late and the intermediate and early precursors, along with various proportion of blast cells to come up. This is due to the acquired chromosomal abnormality of BCR-ABL fusion gene, resulting in tyrosine kinase activity, a gene product which can result in the uninhibited proliferation of the myeloid cell from the stem cells. This is found in all the cells of myeloid lineage as well as rarely in some lymphoid cells. So what you have a reciprocal translocation which can be very easily picked up in the cytogenetics when the long arm of the chromosome 9 comes under the short arm of chromosome 22 with the resulting chromosomal abnormality on chromosome 22 known as Philadelphia chromosome, which can lead to a fusion gene formation called as Abelson and breakpoint cluster region gene fusion called BCR-ABL, Abelson called ABL, and breakpoint cluster region called BCR. And this happened in the chromosome 22. The chromosome 9 part is Abelson, and the BCR is on the 22. The resultant fusion gene is formed on chromosome 22. This can be seen in the metaphase of the metaphase spread of chromosomes, and we need at least 20 such metaphase chromosomes to be visualized in small G-binding group of chromosomes. This fusion gene encodes for a protein which is of 210 kilodalton weight with tyrosine kinase activity, which is uninhibited proliferation. If you remember my nuclear lectures, I spoke about these of the inhibitor activity and resulting in the cell cycle going from G0 phase to S phase with uninhibited proliferation. This is very different from the CLL, where the proliferation was not at fault. The fault was cells resisting their death or they're increasing their longevity. Here what happened, this transduction pathway causes cells to proliferate, and we can see the neoplastic proliferation throughout the marrow and count becoming very high. This translocation is found in most of the chromosomes in 95% of the cases, but could be hidden or cryptic in others and are detected by more sensitive techniques through RT-PCR or FISH. So if somebody does not have the access to cytogenetics, the simple FISH or BCR-ABL can qualitatively at least tell whether this is present or not present, and diagnosis establishment requires cytogenetics and or molecular at the baseline and on follow-up as well. So the natural history of the CML is it is a triphasic disease with these phases: chronic phase, accelerated phase, and the blast phase. And the chronic phase is the most common one, which can persist for years. But this timeline differentiation is a very arbitrary one. Many patients can just go on in the chronic phase for years together. Many might present with the AP phase or the blast phase, or they can show the transition and the jumping and hopping from one phase to another. So it's just a kind of a way to teach you, but it's not really followed in the real practical life of the patient's dealing. So chronic phase is indolent with increased proliferation of cells with normal maturation. AP or the accelerated phase goes for 4 to 6 months, and it's more aggressive. It can progress to the next phase, that is the blast phase, which can happen within the 2 to 4 months. That is, from the AP, it can become the blast phase within a transition phase of 8 weeks to maybe 16 weeks, and it resembles acute leukemia because the blast percentage requirement is same. So what we have the most common form of this leukemia in the adult population, especially in India. About 50% of the leukemias are chronic myeloid leukemias, and it can involve to any age. And as per all other hemato-oncology in India, the age of onset is much earlier compared to West. And it is insidious in many patients. They can come for some other reason. They can come with hyperuricemia. They can come to the orthopedic OPD with the gouging arthritis. They can come to the GI OPD with the complaints of pain in abdomen. And we find on the patient the spleen, which is huge, coming up almost to the umbilicus, thus resulting in the loss of appetite, dragging sensation, and the pain in abdomen. Or they can come up to general OPD with just weakness, fatigue, exertional dyspnea, some weight loss of appetite, and they can come to the chest OPD or to the CVS or to the cardiac, physician with the complaint of the chest pain or the sternal tenderness. So with this, as I told you, any hemato-oncology, the first and the foremost is the CBC and the pepper smear. We see marked lymphocytosis with a count of 100 to 500,000 per microliter, or 100 to 500 per 10 to the power 9 per liter. That is almost up to 5 lakhs with hyperleukocytosis. Hemoglobin could be normal or low, and platelet could be normal or increased. As it's a myelomegakaryocytic stem cell proliferation, you can see thrombocytosis, or you can see thrombocytes. There's a myeloid bulge with bimotor maturation pattern, as I told you, with basophilia, eosinophilia, blasts which are less than 2%, ranging from 0 to 9% for the CP phase, chronic phase. Examination of bone marrow, though again not mandatory, but to work up the case for the first baseline, we have to do cytogenetics, and we also have to do the bone marrow biopsy examination to see what is the pattern and the level of fibrosis in these patients. So there is, as expected, myeloid bulges there. So the myeloid component is much more compared to erythroid. Blasts are less in the marrow, less than 10%, and megakaryocytes are abundant. Biopsy shows paratrabecular cell cuffing of immature myeloid cell precursors, and bone marrow biopsy with loops, clustering, and the dwarf forms in the interstitium, at times away from the sinusoids. So this is what you see in the peripheral smear. There is a myeloid bulge. You can see the band forms, metamyelocyte, myelocyte becoming a metamyelo, promyelo, almost becoming a myelocyte. This is a blast. So what you see, hardly any cell except the myeloid precursors both in early and the intermediate and the late ones. Even in the late ones, you see there's a defect in the maturation. This is a segmented polymer follicular cell, but it's not a normal segmentation happening, and it's a large platelet cytoplasmic fragment. On the bone marrow biopsy, before the bone marrow biopsy, we do the NAP score, which is neutrophilic alkaline phosphatase or NAP or lymphocyte alkaline phosphatase, which is very low. And this is important to differentiate this with the benign conditions, infective conditions, there is a leukemoid reaction where it will be very high. And this is compared to the normal established normal score of 100 to 120, which is compared with here, which is low. But in the leukemoid reaction, it will be more, almost up to 120 to 150 to 200. And in the bone marrow biopsy, there will be myelofibrosis, increase in the megakaryocytes, and they will be correlating with the blast percentage splenomegaly and therefore prognosis. On cytogenetics, I said the Philadelphia chromosome, and on molecular Bcell gene is to be established. Other is increased uric acid, hyperuricemia in the biochemistry. There will be increased vitamin B12 and the increased vitamin B12 binding capacity. This is due to the clonal myeloid cell proliferation. There is increased vitamin B12, and it's a very important surrogate marker of the proliferation of the myeloid cells. Now the next phase is AAP, and that is the accelerated phase. Any of the following criteria are to be used: hematological, cytogenetic, or responsive tyrosine kinase inhibitors. In the hematological markers, we have persistent lymphocytosis, where the count is increased, and or splenomegaly, which is unresponsive to therapy, is persistent thrombocytosis, platelet count is increased, and it is more than 10 lakhs or 1000 in 10 power minus 9 per liter, despite the treatment. That is unresponsive thrombocytosis, which is persisting despite the treatment. So, and or there could be persistent thrombocytopenia, which is less than 100,000 per microliter, which is unrelated to treatment. So anything, any combination, anemia, leukocytosis, thrombocytosis, and thrombocytopenia, which is persistent and unresponsive to therapy, is considered as AP. Here, compared to the CLL, anemia is not given a very huge emphasis for the stage transmission transference compared to the lymphocytes, leukocytes, and the thrombocytes percentage or the count. Also, there is increase in the basophils and or eosinophils in the blood, which is equal to more than 20%, and the blast percentage compared to CP is 10 to 19%. Please remember all these criteria. They're very important because they're asked, and for your own understanding, as you mature from a third prof, a second prof, undergrad students, when you go to the wards and you become an intern, you'll be seeing these patients and you have to understand the basic pathology. So besides hematology, we have cytogenetic and responsive criteria. The responsive criteria are provisional as of now, but cytogenetics is important. Addition of any chromosomal abnormalities in the Philadelphia positive cells, patient at the diagnosis in the form of trisomies and deletions and isochromosomes is considered as AP, and or addition of any new clonal chromosomal abnormality that can occur during the therapy. So whenever we see the hyperleukocytosis and the previous hematological criteria, we have to make again the cytogenetic and molecular assessment to confirm the AP criteria. Now the TKI, as I said, is the provisional entity. The tyrosine kinase inhibitor treatment criteria, that is, we have got different categories of TKIs, grade 1, grade 2, grade 3. In addition of more than one TKI in the treatment regime, they form the other criteria. I'll not go into the detail of it as it's provisional and it's just not under your scope. But those who are interested, they can read about it and can ask me. The next is the blast phase, and it is diagnosed when the blast percentage is more than or equal to 20% of blood or the marrow, and this extramedullary blast collection in the skin, lymph nodes, soft tissue, bone, and CNS, and there is focal collection of blast in marrow, which is quite significant. That means if we see a very small nodular focal collection of blast and no other cell, this is also very, very significant, and we can confirm it by doing maturity markers positivity, that is CD34 and DDT. For the basic of the bone marrow biopsy, we always do CD34 and DDT to establish the, along with the basic markers, that is MPO and B and the T cell marker, if the blast cell percentage is to be established and the lineage specificity is to be checked. Now the prognosis and treatment, as I said, treatment is basically tyrosine kinase inhibitors, which are imatinib and the congeners. We have got class 1, class 2, class 3. Class 1 is imatinib. We always start with it. If the patient responds well or it doesn't, we increase the dose. And if there is a complete failure, we go on to the next stage of the TPIs. If that also is not giving a good response, we add on another one. And in the last stage, we use the stage, we stage the class 3 TKIs, and we assess for the prognostication. Response assessment could be clinical or hematological. In clinical, we look for the disappearance of symptoms in organomegaly. In hematological, we look for TLC, GLC platelet count, which could be normal. And if the cytogenetic response is seen, which is seen in the 20 metaphase studies, they should be negative. It's a good response. Major molecular response is done by the quantitative RT-PCR. The 3-log reduction of the PCR is considered MMR, that is a major molecular response, and CMR, the complete molecular response, the most sensitive test by doing the residual disease assay, which could be again RT-PCR, the quantitative one, and or by a high resolution MRD by the flow cytometry. Now we come to the third component, a third topic of our lecture today, which is the multiple myeloma or the clonal proliferation of the plasma cell neoplasm. And I'll go very quickly into it because I do not have much time. So this is, as the name suggests, it's a clonal process where the plasma cells are undergoing neoplastic proliferation. Here, basically a multifocal disease associated with the bony lytic lesion. There's hypergammaglobulinemia with associated M protein. There's a monoclonal protein which is found in the serum and urine and can result in the organ damage due to the plasma cell proliferation or and with the associated M protein. The diagnostic criteria laid down for the diagnosis of plasma cell myeloma are by the International Myeloma Working Group Committee, and the latest criteria had come in 2010, followed by minor modification in 2016 to 18, and this says that the clonal plasma cells should be more than or equal to 10%, or it should be a biopsy-proven plasmacytoma, and one or more than one of the following myeloma defining event. These are very important. Please pay attention to them. There has to be an end organ damage, which is attributable to plasma cell proliferative disorder. There could be hypercalcemia, which is more than 111 milligram percent. That is almost 1 milligram of the upper limit for the age cutoff mentioned. And the renal insufficiency, where the serum proteinuria is more than 2 milligram percent, and anemia, which is less than 10 gram or less than 2 gram for the upper limit for the age mentioned. There has to be bony lytic lesions on radiology, could be one or multifocal or more than one. So all these things, they make the component which is called CRAB, that is hypercalcemia, renal insufficiency, anemia, and the bony lytic lesions. These 4 components are called SCRAB and end organ damage attributable. So any of the features or more than them, along with the clonal plasma cell proliferation. We can also have the biomarkers, that is the biochemical markers. Along with them, the one is uninvolved to involved serum free light chain ratio, where the involved is more than the uninvolved and the ratio is more than equal to 100. That means we have got the kappa and the lambda light chains and if the kappa is more than the lambda and the ratio is more than 100, it is considered to be abnormal. Then the clonal bone marrow plasma cell proliferation, which is more than 60%, the one single marker is more than enough. And if we have got more than one focal lesion in MRI, again it is very, very important. Then compared to PCM, which is manifesting, we have a one which is not manifesting, which is silent, asymptomatic, and it is called smoldering, where the criteria which are made for the PCM are different here because the involved immunoglobulins are lesser, and the excretion of those immunoglobulins into the urine is also lesser, and the clonal plasma cell percentage is though nearly same, like between 10 to 60%, but the most important is the absence of myeloma defining events are not completely fulfilled. So it is important to assess the M protein quantification and the quality, that is which one is there. Most likely involved immunoglobulins is IgG followed by IgA, then EMG, and very, very rarely IgM, unless we're talking about the Waldenstrom's macroglobulinemia or lymphoplasmacytic lymphoma. The M protein excretion is equal to more than 500 milligram in 24 hours urine. So 24 hours urine is very important to be done in myeloma cases of clonal plasma cell, as I established earlier. Now, why this happens and what is the epidemiology? What is the global distribution of this disease? This disease is a deadly disease. It is 10 to 15% of all hematopoietic neoplasms. 20% of all deaths are due to hematopoietic neoplasms. Arise of all the hematopoietic neoplasms are due to the myeloma. It's much more common in the black compared to white, and the males are more commonly involved in the females, and they do bad. And the Indian population, as stated earlier, like all lymphoid malignancies, the population which is involved is much younger compared to West. Now, what is the etiopathogenesis of this? The etiopathogenesis is this, that the chronic antigenic stimulation or exposure due to infections or toxic substances or any other disease like autoimmune disorders. Chronically, when this exposure happens, this can result from the polyclonal gammopathy to switch to a monoclonal one and can result in the clonal plasma cell manifest proliferation resulting in plasma cell dyscrasia. As I described earlier, this patient can present with any of the features. They can come to the nephrology unit for the first time with complaints of puffiness of the face or the fetal edema or extreme degree of fatigue, or they can describe some urinary symptoms, or they can come to the general physician or to the hematology unit with anemia and extreme degree of fatigue and infections which are happening on the recurrent basis, or they can come to ortho with bone pains which are unbearable, or pathological fracture, or fractures with a trivial or a minor trauma. So, but when we talk about the Indian scenario comes with a bulky disease with lytic lesions, renal insufficiency, hypercalcemia, and anemia, thus with the crab features much worse, much more than the Western counterparts. So, as expected, the lab diagnosis will be cytopenia of variable degrees on the CDC and PS. That smear will show you rule information with variable degree of cytopenia and circulating plasma cells. This is very important component in all the plasma cell myeloma cases. The PEPFAR smear should be examined very nicely for rule information and the type of anemia, and also for circulating plasma cells. If they are more than 20% of all the cells, this is called plasma cell leukemia, which can coexist, which can predate, and which can follow the treatment of the plasma cell myeloma. Or in general, in the Indian population, they can be up to 2 to 5% of circulating plasma cells at all times. Bone marrow examination, the bone marrow aspirate is very, very important. It can show you the variable degree of plasmacytosis. It's one of the defining criteria for plasma cell myeloma diagnosis. It has to be equal to or more than 10%. Biopsy will show you diffuse interstitial deposits of plasma cell. Very rarely can show you paratrabecular and nodular deposits with or without amyloid deposition, where we need a special stain, especially the PAHAS and the Congo red or the metachromatic stain, tall blue and all. And for the flow cytometry, we again put up these cells in the bone marrow aspirate, EDTS sample for the markers like CD38, 138, 56, 19, and light chain restriction expression, and along with the surface immunoglobulin expressions. I'll be showing you in the subsequent slides how they come up. The atypical plasma cells are always negative for CD19, though it's a Bcell, progenitor, Bcell, cell which has become a plasma cell or a memory cell, and but they are neoplastic, so they lose CD19 expression and they acquire 38, 138 expression and dim to positive, dim to moderate or to negative CD56 positivity, which is quite variable. But they have to show a light chain restriction, which is either kappa or lambda type with altered ratio, which can be established even on the flow cytometry, along with surface immunoglobulin expression, more commonly IgG, followed by A and D. So biochemical expressions or the markers are very important for the prognostication and the follow-up of the patients, out of which, as I said, serum free light chains are the most important, with the ratio which I said more than or equal to involved to uninvolved, 100, and the range of the serum kappa light chain and the lambda light chain is 0.26 to 1.25, 0.26 to 1.25 in the 1.65 in the normal healthy individuals. But if it is more than that, it is considered to be the abnormal and the, of course, uninvolved and the involved ratios. So we do the serum and urinary protein electrophoresis, where we establish the M band, and the M band looks like this. So what we have the electrophoresis. Here the blood is applied, and the migration of the protein happens. And this is the graphical presentation of the protein. The first protein to migrate as per the molecular charge and the weight is albumin. And the farthest is the globulin, which is the heavy one, and is the lighter one, so it goes farther off, and this is the last one to come. And we can see a sharp peak which is almost equal to the albumin peak. That means the ratio of albumin to globulin has altered, it has changed. Otherwise, in normal individual, albumin is more than the globulins. In between, we have got alpha 1, alpha 2 globulins, beta 1 and beta 2 microglobulins. And here is the urine, where the urine application of the patient results again in the M protein, which never is a normal finding in the urine. Now, this is the electrophoresis with immunofixation so as to establish what is the qualitative, marcation of the immunoglobulins which are being represented in this patient at the clinical concentration. So this is primarily IgG type of the fluid plasma cell proliferation secreting the IgG, and this is more, whereas A and M are not there. That means it's just that, and I'm sure when we do the quantification of this, which is missing in the slide, this was more than 3.5 grams. And the kappa light chain restriction compared to lambda shows again it's a clonal disorder, and the same is being depicted in the urine. So what we see is the immunofixation and the quantification. IgG is more than 3, IgG is less than more than 2 in general. Urinary protein is very high, more than 3 grams. It's very important. Serum calcium is 11 milligram percent. I told you hyperuricemia is more than 6 milligrams because of increased cell turnover rate. Create is high, protein is reduced with reversal of A to G ratio, and there is decrease in the albumin because of this. The AG ratio is reversing and reduce now normal uninvolved immunoglobulins. Like in normal individuals, individuals, we have got immunoglobulins. Highest is G, then A, then D and E, and the least is M. And this normal cutoff is also reduced, and we have all the clonal immunoglobulins to this extent. LDH is raised in those who have got poor prognosis. Beta 2 microglobulin, again more than 3.5, is considered poor prognosis. Morphology, what we see is the cells which have got the eccentrically placed nucleus, but there is loss of nuclear perinuclear hop, and this is a cell which is seen in the blood. So it was a case which I diagnosed as the plasma cell leukemia, and you can see there is rule formation and hardly any other cell. This patient had plasma cell in circulation, and at the outset itself, the patient presented with plasma cell leukemia and marrow. When I did the marrow examination, marrow was full of plasma cells, which were about 80%. This is the marrow of the same patient. You can see different types. So even these bare nuclei which are seen with the cytoplasm has been stripped off, they are plasma cells. So we cannot count them as unless we have got these types of cells, they are all plasma cells. Hardly any band other cells like some band forms are seen, no NRBCs can be seen, no erythroid precursors or megakaryocytes can be seen. So this is what you see in the marrow. This is the bone marrow biopsy. This is a diffuse involvement of the bone marrow biopsy. This interstitial pattern with the megakaryocytes could be seen. This is a nodular pattern of the plasma cells. This is the trabeculae, which is seen trabeculae. Another small nodule, and small nodule. This is a plasmablastic leukemia, myeloma, where the centrally placed very large nucleus is seen. And this is the kappa light chain restriction, this is the lambda light chain restriction in a plasma cell myeloma, the two different cases. This is the cytogenetics basics I would like to describe. This is one case where the 20 chromosomes metaphase spread is seen, though it is more than that, but it is the minimum we should have. So we can see that this is a spread and metaphase spread is there. When we align them as per the their size and the morphology, there's a chromosome 1, 2, we can see multiple trisomies are there. That means when we have a look of this, we can see this is a very busy, spread. Why? Because the hyperdiploidy is there and the chromosomes are much more increased in the number. This was called 3 chromosome at chromosome 3, and this one again has got 3 chromosome at chromosome number 9. There are 4, that is there's a tetralogy which is happening here, again 3 chromosomes here, and what we can see there is a loss of chromosome 3 here, and there is part of chromosome, loss of 4, and the part of 3 has come here. So there's a translocation, and part of this has come to on this chromosome as well, where 3 and 4 have come on the chromosome number 14. And then we have again tetra, then again tetra, again trisomy, and we can see there's a huge disarray in the form of hyperdiploidy and complex karyotype in this patient. Though hyperdiploidy is considered to be a good prognosis, but complex karyotype makes it a little intermediate one. But pure hyperdiploidy is considered a good prognosis. Now this is another one where we can see that the trisomy happening here, there's a translocation happening here. Part of this chromosome, which was trisomy, has come and got stuck to this chromosome, which is chromosome number 5. And similarly, we have got the other picture is nearly same. So there is some sort of aneuploidy in this pattern also, but compared to this one, this is not that bizarre. So now we come to the flow cytometry, which is the integral part of the myeloma. This is one of the cases which I reported. Here I said, here we can see that the plasma cells are 45 negative. So plasma cells are very tricky cells. They can show the 45 negativity, they can show you weak 45 positivity, or they can come in the monocytic region here, and then after we gated those 45 negative cells, we found that they are expressing 38 and 138, which is moderate to bright, which is coming to second decalog. So further gating, we found that these are showing kappa light chain restriction, no lambda light chain, because anything which is less than 10% is considered to be negative. Here, what we have CD56, which is negative, and 38 positive cells are not showing 56 positivity. 56 could be positive, it could be negative, or it could be weak in the atypical plasma cells. CD281 as a prognostic marker, 200 is strong positive and it's a poor prognostic marker. So this we do routinely in all the myeloma cases on the bone marrow aspirate as a standard treatment diagnostic modality. The cytogenetics and the molecular study which we do is hyperdiploidy, as I said, is a very good prognosis in the 40% of the patient. Fortunately, have that, which I showed in the first of the metaphase spread. And the non-hyperdiploid include are the 45%, which include transcription 1114, 1416, and 414, out of which the 414 is the intermediate prognosis, and the 1416 and 1114 and 17p 13 deletion are the poor prognosis. Fortunately, they are not so frequent, and the non-hyperdiploid are anyway lesser than the hyperdiploid, and out of which even the 414 is intermediate. So we are lucky that the poor ones become in the other ones, and they are not so frequent. This is how the lytic lesions look into this. One of the cases which I showed you, the plasma cell leukemia patient with the myeloma. This is the X-ray of that patient, and it required multiple lytic lesions all along. Can you see that the outer table and the inner table are so thinned out there? They are showing separation, and there's a breach here, and this is a lytic lesion all over here. So this is the latest staging and the stratification criteria, which is the International Staging System, ISS. Here we add the prognostication markers for the cytogenetics, intermediate, good, and the poor one. The poor one come here, intermediate here, and the good ones, that is the hyperdiploidy, comes here, and 414 here, and the rest all division 17p, and the 1416 they come here. So the criteria is the stage 1, which is serum beta 2 microglobulin, which is more than 3.5 gram per liter, and stage 3 is when it is more than 5.5. Anything which is in between that is stage 2, and the median survival range is from 29 to 62 weeks with intermediate of 44 weeks, which is approximately just less than 4 years. And this is not even 2 years. And myeloma is a very dreadful disease with a poor response to therapy, but now with the addition of the newer treatment modalities and the targeted therapy, this is becoming a promising disease. And with the condition of the patient allowing the autologous stem cell transplantation at the outset itself, with the first induction phase itself, can give a good median survival in these patients. So with this, I end my lecture. And thank you for your attention. And I know I overshot my presentation because the topics were, 3 earlier with, earlier batches we used to take 3 such lectures separately. And with your, batch suffering due to the COVID, we have to club the lectures together to complete your syllabus. I'll be more than happy to take up any questions, anything which you couldn't understand. Please let me know. Any questions, please? You can write in the chat box. Okay, if none, then I take your leave. Have a good day. Thank you so much for your attention.